my training as a GI fellow in St. Louis University back in 1994. At that time, EUS was developing in the United States. So I did I had some experience in the US, and I performed my first EUS procedure in 1995. That's 22 years ago. At that time, it was only radial diagnostic endosonography. I got my first real experience when I finished my training and I moved to Cleveland, where I did my advanced therapeutic endoscopy training. And that included dedicated training in EUS by world experts in endoscopic ultrasonography, namely Michael Sivak and Amitabh Chak and Richard Wang. By the end of the training, I was able to publish a few papers, namely on EUS mini probe and other aspects of EUS, clinical utility, things like that. After that, I moved back to Lebanon, and I worked in the American University of Beirut, which is an academic medical center, and I was the therapeutic endoscopist, and I brought the EUS technique to Lebanon. And since then, I've been doing, I would say, a large volume of diagnostic and therapeutic EUS, mini probe, radial, and linear with therapeutic applications. Over the past years, I was involved with a lot of the pioneers of EUS, namely Marc Giovannini from France and Peter Villman from Denmark and other people in Europe. And I became a member of the prestigious Euro-EUS. And this helped me to, in terms of few things, namely doing EUS workshops all over Europe, and then I was starting to spread the EUS word in the Arab world, in the Middle East and the Far East, and Lebanon is part of Asia, so I became a member of the Asian endosonography group, and I'm beginning to become more active in the EUS field in Asia in general, especially East Asia, because I present West Asia. So between the Middle East and North Africa, East Asia, Europe, and where I trained in the US, I would say that I've been involved in a lot of global endoscopic ultrasound technology and training for many of the physicians, established or the trainees who are interested in endoscopic ultrasound. First of all, the indications have to be the correct one, and any endosonographer has to understand that there are the sound indications for EUS, but they are namely staging and management of pancreatico-biliary and GI malignancy, evaluation of subepithelial lesions, and some other things like, for example, the chest, the mediastinum. We do a lot of those because it's one of the main techniques to diagnose the lymphadenopathy in the mediastinum. So we got a chunk of the work that usually the pulmonologists would do, and they are the ones who would refer things to us. So between the chest, pancreatico-biliary, luminal, subepithelial lesions, non-malignant disease like CBD stones, we're in the process of publishing a paper on 600 patients over the past 10 years on how EUS practice changed the way we practice ERCP. Like, for example, in the past, when there was somebody who had a high risk for CBD stones or intermediate, they would go straight to an ERCP. Nowadays, with this paper that's going to be soon published, we showed that if you do an EUS, a big chunk of the patients who would have gotten an ERCP would not get an ERCP because the EUS showed that there is no CBD stone. So basically, first of all, we have to understand the indications, and then you have to have a machine or a system that would be able to answer this. And I think a system would really involve the radial scope, the linear scope, which is the most important, and the mini probe. And I think if you combine them all in a system that is compact, that is sound, you'll be able to do almost everything you want to do in the field of endoscopic ultrasonography. An excellent question. Initially, the EUS imaging, the ultrasound imaging, so to speak, relied on separate systems like the Hitachi system, like the Aloka systems, etc. But they are like big machines with that are very pricey, and they are big and bulky. Nowadays, there is more the compact system, and this would not sacrifice the quality of the imaging, the ultrasound imaging, and at the same time the optical imaging has improved, as we know in general endoscopy. So we do have now compact machines that are able to provide outstanding ultrasound imaging, and of course the advancement with the optical system, we can get excellent optical views. have experience with basically all the EUS systems, the Olympus, the Aloka, and the Pentax with the Hitachi and the Fujifilm. And it's important to mention what some of the developments over the past, I would say, 15, 20 years in the US. Now we do have the elastography, which is basically the study of the elastic properties of tissue, which can be helpful in discriminating malignant from non-malignant lesions, pancreas, lymph nodes, etc. We have the contrast-enhanced EUS, which is also something very helpful in differentiating a malignant lesion in the pancreas from an inflammatory lesion. We do have the power Doppler to avoid vessels, etc. We have the therapeutic implications of EUS, which are really expanding fast. There is competition as far as diagnosis and staging between EUS as a diagnostic modality and, of course, the MRI. MRI has evolved very nicely, very beautifully, and the multi-detector CT technology. But still, EUS plays a role specifically in the locally advanced GI or pancreaticobiliary lesions. It does hold an advantage. And on top of that, the therapeutic implications opened a big door, like therapy of pancreatic cysts, therapy of pancreatic malignancy with RFA, with injection therapy, therapy of, for example, bypass, like bypassing the biliary obstruction using EUS, drainage of pancreatic pseudocysts or pancreatic collections. All these involve EUS, and they have really emerged to become, I would say, standard of care in many centers around the world as far as the management of certain diseases using EUS technology. That's an excellent and very technical question that many gastroenterologists, namely the starting, the budding endosonographers, will ask. Number one, if you're still talking about the radial echo endoscope, it's important to have something with not with side vision, but with forward view, which means that it will be like a regular scope, so what you see is what you get. So this is important. Second, the caliber doesn't have to be too big. It has to be small, and it has to pin, which means totally retroflex. In this way, you can use it as a scope, gastroscope for diagnostic purposes, and at the same time as an EUS scope. And of course, it doesn't have to be very big. So I look for these qualities in the diagnostic scope, being able to do a total pin, thin caliber, and forward viewing, so I can use it both as a gastroscope and as an EUS scope. As far as the linear, or the one that is the major one, it's important to have the big channel, because we have to do therapeutic procedures. So you have to have a big channel. You have to put sometimes a stent. You have to pass things, maybe RFA, radiofrequency ablation probe, which is big, a big needle for Procore. So it has to be big channel. It has to be flexible enough, and I like the tip to be small. And the better if we have more of a forward type of view, because the side viewing have been implicated in many cases, especially in training of perforations, namely at the apex, the duodenal sweep, because this is the blind spot and fellows cannot appreciate it very well. I would think that the best one in the market is the one by the Fujifilm, and the reason being that's the only one, to my knowledge, that is you can fully retroflex, which means full pin, so you can use it as a gastroscope. It does have a channel that is 2.8, so you can use it to get biopsies like any gastroscope, and it's thin in caliber. While as far as the linear, I think it's important also the Fuji for one reason, is that it is as closer as you can get to a forward viewing, which means that you see, although it is a linear probe, but unlike others, you can see fairly straight, which means that you would avoid many of the problems that the beginners would face. The other systems it's very important. Other systems are fair, they are good quality, but I think for trainees starting, it will give them an edge to have a view. And the third thing, which I didn't mention, is the mini probes. And the mini probes are very important, and I genuinely believe they are very underutilized. I think mini probes play an important role in big centers and tertiary care centers, because there are some blind spots, so to speak, that is filled by the mini probe, namely small lesions, because you can put the mini probe next to it, namely things that are in the pancreaticobiliary system, because you can put it in the pancreatic duct or the bile duct, and you can even evaluate certain IBD cases using the mini probe because you can put it in the lumen. I find it helpful because you don't need to do a dedicated procedure. You can do it during any gastroscopy, colonoscopy, or duodenoscopy. So it doesn't involve an additional procedure. You just put it like you put a biopsy forceps. You get it out and you get the imaging. So it does have some advantages and some indications that are important in big tertiary care centers with complex diseases. Many things are being cooked, and hopefully in the coming 3 to 5 years you will see even further advances in EUS, and hopefully it's here to stay. It's not an aberrant technique. It's one of the solid techniques in gastroenterology, and I think the more we train our fellows, we'll be able to pass this knowledge to them because the new generation will have to carry the flag and continue.